Okay, today I'm going to discuss about the dynamic retinoscopy. So basically, static and the dynamic, there are two types of retinoscopy. So dynamic retinoscopy today I'm going to discuss about. So I think it will be a very, I think significantly long video because I am going to try to cover it in one video. Let's see what happens. So basically, introduction of retinoscopy actually outgrowth from the ophthalmoscopy. That's the basic concept. So William Bauman and it noted the change in the light and shadow occurred within the pupillary border when he tilted his ophthalmoscope. That's why ophthalmoscope is a precursor of retinoscope, as we already told you. In early 1900, various investigators began utilizing retinoscope to determine the amplitude of accommodation status in a non-verbal patient, especially patient who cannot speak. So that term is dynamic retinoscopy. Dynamic means changing, isn't it? So objective method to determine pattern and refractive area at near points. So at near point, you always know what accommodation comes into play. So that's why in static retinoscopy, accommodation is static, zero. There is no change in the accommodation. In dynamic retinoscopy, accommodation comes into play. That's very important difference definition. Static itself, accommodation is static. Dynamic itself, accommodation is in a dynamic play. Okay, accommodation is not at all at rest. Okay, so AJ Cross is credited with the introducing the basic theory and method of the dynamic retinoscopy. And after all, Sayers, Nott, Scaff, Skeffington elaborate the theory and procedures. Okay, so the goal is to determine the accommodative response, which is basically lack of accommodation and all these things. Also help to determine the most appropriate near prescription for testing condition. For the particular testing condition, it helps us to determine most appropriate near prescription. Reveals the degree at which accommodation is fluctuating, isn't it? Accommodation is not at rest, fluctuating when attending in a near target if I are balanced equally at near. So provide the information and insight regarding the patient's ability and visual processing at the chosen distance, means chosen distance at near, definitely. That's why it's also called near retinoscopy, dynamic retinoscopy and near retinoscopy. So the cross method, the person who coined this term, the cross method, AJ cross. See, an alternative to cyclophagic refraction. I don't know how much it's correct because it definitely dynamic retinoscopy is not an alternative to cyclophagic refraction. But yes, definitely, if cyclophagic refraction is contraindicated, at that point we think about Mohinder retinoscopy and other things. Okay, the method of adding plus power to obtain the reversal. Basically, for the near, just we add plus plus plus, and when reversals come, so cross method helps to determine cases of astigmatism, presbyopia, and subnormal accommodation in young patients. So the limitation is basically when you put too much of plus, it means definite negative relative accommodation, isn't it? So by definition, negative relative accommodation is to measuring by when NRA is measured by putting plus. So plus power recommended and patient would not persist. So then comes here the another term is Sets method. Sets, basically Charles said in 1920 introduced the concept of lag of accommodation. Then he is the person who introduced the concept of lag of accommodation. So add plus lens power until the neutrality occurs. Okay, that's the concept. And another concept, another person who is very famous in the Tate's method, 1953, walking distance is 33 centimeter. That's why the fogging with a considerable amount of plus lens power, and then the approach is neutral by reducing the plus lens power. So basically, a high number of power plus power is added in Tate's method. So found the average approximate of 1.5 to more in shared system you find approximately 1.5, then total lag of accommodation is 2.5. So to close 2.5 negative relative accommodation, that's why in case of Tate's method you find negative relative accommodation which is a little bit higher, but in Sayers method it's a little bit lower. So low neutral and high neutral methods basically means, see, Sayers method is low neutral method at the end of the least plus required for the neutralization reflex. Plus cross method, high neutralization method. So additional plus is power beyond the neutrality until the reversal is occurred. So in cross method there is high plus is given. So these are all the things about history. I don't know about these many things because what we use clinically and what I have been using is monocular estimation method, not method. These are the very Bell method. These are the very useful method in clinical cases. So let me discuss the very useful method, which is the number one useful item. I think the monocular estimation method, that is aka MEM method. So attributed by Dr. Holland, Hirons, and Pacific University College of Optometry, and give estimate measurement of the spatial position of accommodation of regard of convergence with regard of convergence. Just understand the points: spatial positioning. So cognitive demand is moderate. Patient needs moderate cognitive demand. So this is the chart. See, around retinoscopy strip, we add this chart, and patient, we ask the patient to focus on this any of these images, isn't it? The series of card is a central aperture is mounted on the retinoscope because centrally we are looking through the retinoscope. The card have printed letters, words, or pictures ranges from 2060 by 2030. So arranged around the aperture. So it's very important. Sometimes you see this, isn't it? So basically, instruct keep the target clear from the patient and sweep the retinoscope beam and observe the motion of the retinoscope reflex and quickly intercept the trial lens of the spectacle plane. Basically, whenever we sweep the retinoscopic uh, reflex, we have to interpose quickly that trial lens because the lag of accommodation is the amount of plus lens that neutralizes the reflex. So when we add plus lens, eyes itself relax. That's why higher chances of getting more plus. That's why we have to sweep the lens very quickly. Okay, has been found accurately measure the lag of accommodation in an objective manner, which is very useful method. That is MEM method. It's as a student, it's very important to understand. What is the limitation? Plus lens relaxes the accommodation. Accommodative response measured by the value of 10% or less, no longer than the 1/5. That's why I have told you that no longer put the plus lens for too long. You have to switch very quickly. Okay, what is another method? It's a Nott method, that is not dynamic retinoscopy, not on near retinoscopy, developed by IS Nott in 1920s. Main purpose to determine the uh, main purpose is to identical to MM method. So cognitive demand is moderate in this case too. The material reduce the block 20 by 20 letters is placed 16 inch from the patient. Okay, just remember here 16 inch from the patient, and in case of MEM retinoscopy, we place the object that patient focus in around the retinoscope beam, isn't it? So procedure is where his compensating distance lenses. It's always important in retinoscope. We always assume that distance refraction is corrected, isn't it? So directed to the letter reading letter, perform the retinoscopy by moving farther from the plane of regard until the motion of neutralize. Basically means patient is fixating. See, patient is fixating at a particular distance and reading the letters or whatever, then we as an optometrist should move in front or behind and we find the neutralization position, isn't it? So patient is having where is company, basically patient is taking at the 40 centimeter these letters 20 by 20 letters and performing retinoscopy by moving farther from the plane of regard until the neutralization. If farther from the plane of regard, then it's definitely lag. If in front of the plane of regard, then it definitely it's lead. So that's the picture of not retinoscope. So interpretation, dioptrical difference between these two distance equals to lag of accommodation. See, if here is the patient reading this distance and I am neutralizing from this distance, then the distance gap, this is actually lag of accommodation. Here is the letters that patient is reading and here I am neutralizing him. So this that's gap is basically lag of accommodation. It can be valuable evaluating stability of the accommodation response. If I am not neutralizing from here but from here in front of the, then it's definitely lead because the gap is here now. This is lead, isn't it? So that's the basic principle. If I neutralize behind, it's lag. If I neutralize moving forward, then it's lead. It's always simple as that. Okay, just remember that. The distance from the target spectacle plane is 40 centimeters, for example, and the distance from the retinoscopic spectacle plane is 50 centimeter. So lag of accommodation is basically for 40 centimeter, that's demanding 2.5. What actually patient is accommodating? 2 diopter, because patient is accommodating neutralizing at 50 centimeter, then lag is 50 meter. Isn't it that simple? You just have to calculate it. 40 centimeter, demand is 2.5. Actually what patient is accommodating is 50 centimeter, that is minus 2. 50 centimeter is 2 diopter, isn't it? The difference is 0.5 diopter. That's the lag, it's not lead, for God's sake. So let me give an example for lead. Patient is 40 centimeter, 2.5, and you are neutralizing at 30 centimeter, that is 33 centimeter, that is 3 diopter. Then 2.5 minus 3 is equal to minus 0.50, that's the lead. If you do all these things, then that's the lead. Okay, that's the lead. Okay, so Bell retinoscopy. This is another fascinating retinoscope developed by Dr. W. R. Henry and R. J. Apple. So, evaluating and performance of the accommodative system under moving or real life condition free space, because it's free space. It's Bell that's moving. Its cognitive demand is low. So, three-dimensional beam target, that is a bell, definitely a small, highly reflective bell, a dangling string placed in wolf wand for 1.5 inch diameter, metal ball mounted in the end of the rod. So basically like this bell. So wand is held by the examiner and moved close or farther away from the patient slower than the 2 inches per second. That's the speed. That's a procedure, isn't it? So retinoscope is positioned at the fixed distance, that is 50 centimeter. Patient fixes the target and examiner notice the direction of reflex. So target is moved close to the patient. Here will be the point where the motion changes from with to against. The target is again moved away from the patient and with the motion is observed. So interpretation is distance between the retinoscope and the target when motion change occur physically measured with the lag of accommodation. That's a very simple thing. See, if here is the object, in if here is the retinoscope, then the distance is, again I have told you, that's a lag, isn't it? For lead object, retinoscope must be in front of the object, so that's not going to happen. So basic thing is another width to against motion observed from 35 to this inches. Okay, 35 to 42 centimeter, then against to width is measuring from 35 to 40 centimeter. So accommodative flexibility can be assessed by observing how quickly and sluggishly changes. But basically eye movement control can be assessed by judging the extreme extent of the ball can be fixed, and near point of convergence can be determined by normal means. So eye hand coordination can be evaluated by asking the patient to touch the wolf ball during the procedure. Limitation is patient converges scoping more off axis. It can be happen, isn't it? Patient is more converging than our retinoscope is not at the center but at the periphery. So it can, in that case, retinoscopy can be off axis. That's the limitation. So now basically, let me finish it first. Basically, in this case, this is the one, this is the ball, and when patient fixated the ball, we are actually behind the ball. That's why we try to discover lag, isn't it? That's the target, and that's where our retinoscopy is. Then the distance, here the patient's eye, isn't it? So their distance is always lag. So Bell retinoscopy is always lag. And stress point retinoscopy, that's developed by the Harmon and Kansky, evaluated in the response of entire organism to stress. So basically stress point retinoscopy looking to the change of the reflex quality. That's what. Okay, in stress point retinoscopy we are looking for changing of reflex quality. So cognitive demand is moderate to high. So basically cognitive demand is moderate to high. Reasoning behind the stress point retinoscopy is that vision is in, in intimately related to the whole body, and that physiological changes stress occur in the body can perceive throughout the change in retinal reflex. Three things can occur at the near point stress experience. First, there is change in the individual pulse. Second, there is change in inner canthal twitch, and last, change in color of the retinal reflex is observed. So procedure is wolf ball is moved closer to the patient, and at which the distance reflexes pop up of the eye, initially brightened and then become dull. Final reflexes again mean pooping in the reflex about 4 inches in front of the patient. So I think this procedure is relatively, we haven't done this procedure, but it's just in theory. We just try to read it as a theory, not as a practical thing, because I don't think I have done this procedure before. The distance is noted and the difference of lens placement binocularly particularly repeated. Ideal lens is one of which make stress point close to the subject if possible. I don't know about it. Okay, so let's skip it. So, book retinoscopy for the sake, I'm just trying to discuss this. So, developed by the Gassel initial child, developed by Yale University, and develops to obtain information about the visual processing and non-verbal infant, and cognitive demand is high. Definitely, the patient is given reading material. Retinoscopy is performed at the subject reading aloud. The information is gathered real time with the task that is close to the normal work situation. So this too describes the following response level with the technique. First section is free level reading level, describes the reflex varies from neutral to with, and another is instruction level, more demanding than the free reading level, and reflex is varying fast against the motion. That's the difference between two. Okay, at frustration level, even though the subject is focused on the page, he is not interpreting information properly against the motion. The reflex color is bright and white when word are understood. So that's another level. So red reflex color are more pink and dimmed slightly to the patient's resting than this. The reflex color dull and brick color when the patient has given up the comprehensive word for reading patients. So there are a lot of things that go. Last two were definitely I wasn't interested to, and so just read as an reading things. But far more important is MEM, Nott and Bell written. So these are far more important. Now we have to understand what is the concept of accommodation, lack of accommodation. That's a very important concept. Okay, lack of accommodation is accommodative demand minus accommodative response. See, this is your eye, and suppose this is the object. Now suppose this is the distance of 40 centimeters. Suppose, what do you mean of 40 centimeter? Isn't it 2.5 diopter? Just doing conversion. Then the eyes must have 2.5 diopter accommodation, but it's not there always. So I try to not to accommodate like 2.5 diopter, but to accommodate lesser. And the main reason is depth of focus, definitely lesser, which is 50 centimeter, which means actually response is 2 diopter. So that's the gap between this. I have already is a lag of accommodation. Okay, if this is the demand and I accommodate more than demand, then it will be lead of accommodation. Okay, the lags are greater when the closer the test distance is used. The closer the test distance, like 10 centimeter, lag is higher. The lag of accommodation exhibits a slow but progressive increase towards adult level. It's always important. Binocular accommodative system usually responds with only 0.575 to 2 diopter increase in plus power. So lag of accommodation, normally lag of accommodation is this. It's very important. Always ask in the MCQs. Higher is this if lead is this. It's not normal. Okay, 0 is not at all normal. So mean lag of accommodation is varies from studies, but it's always that for the 40 centimeter. See, so there are three things almost lead from all mean method. See, in this case a little bit higher, Christian et al. Otherwise almost 0.35, 0.25. Okay, that's the mean. Like the average latency of accommodative response is 370 milliseconds. Just remember this. Average total response including the latency and change in crystalline lens power is about 1 second. Both of the thing. The mean difference between MEM and Nott is very, very, very low. Okay, lag measured with Nott were lower than the lag measured by MEM in high lag subjects. Okay, that's in high lag subjects only. So lag greater than 0.7 or high lag, inadequate accommodative response as a result of near esophoria, poor negative convergence, accommodative insufficiency, uncorrected hyperopia, or patient with over minus. It's very important. But at the same time, lag less than 0.5, that is over accommodation. As a result of near exophoria, you can see that spasm accommodation, over plus correction, inadequate positive convergence. So Parallel Chao et al. Reported that a Nott method was more appropriate testing to assess lag of accommodation in young, because it is the method of least contaminated the result. So basically, Nott method is better for the young case. So other methods are binocular cross cylinder method and near duochrome method, but they are subjective methods. Okay. So in case of subjective method accuracy, when compared with the near bichrome test and near cross-cylinder test, dynamic retinoscopy gives the best agreement to the accommodative response measured with the auto-refraction. So basically, control is auto-refraction. Okay. So in that case, definitely dynamic retinoscopy is better. So confused, near retinoscopy or dynamic retinoscopy. So Mohindra retinoscopy, fellow eye is passed, performed in near infant and object measure refractive correction for the distance, and correction factor is subtracted from the neutralizing lens. So sometimes Mohindra retinoscopy is very useful, and sometimes it's done in patients with contraindication of what do you call it, that cycloplegic refraction. So radical retinoscopy and dynamic retinoscopy. Radical retinoscopy basically doing on patient with small pupil or media opacities and all these things to observe the reflex. So we have to move closer and a little bit off axis. So in summary, dynamic retinoscopy technique. See, lag you can expect monocular estimation method this, Nott method is closely this, but Bell method and stress point method and book method, they are a little bit different, isn't it? So just watch all the things and see all the things and compare things. Okay, just pause the video and compare things. Okay, so the reference is definitely Boris, clinical refraction. Okay. So I suggest you to read by your own, and three things that you must understand and must read is MEM method, Nott method, and Bell retinoscopy is very important. Okay, be done. Choose.